On this opening slide, you might wonder why I'm talking about or have quotes here on the tsunami that occurred on Boxing Day in 2004. But these two excerpts really struck me as something of a parable that got me thinking about how knowledge is produced in the area of HIV. So in the first quote, you see a little item from BBC News that says traditional knowledge handed down from generation to generation helped to save ancient tribes on India's Andaman and Nicobar Islands from the worst of the tsunami, anthropologists say. And then in the second one, you've got an example of a high-powered seismic detection system funded by the U.S. government as a response. What struck me about these two excerpts is, number one, is about indigenous and anthropological knowledge. It's very low-tech and very effective. So in the tsunami, which killed almost 250,000 people, the indigenous people of these two islands had a very low death rate because of traditional knowledge. They knew that when the tide went out really far, run for the hills. That was a simple solution. It worked. And it's such a different kind of solution than the solution in the second quote, which is very high tech, very expensive, and a completely different way of thinking about how to address a natural disaster. So that got me thinking about a question in the sociology of science, and that is, the sociology of science asks, how are researchers and diseases and funders and governments and community members all organized together into a system that produces knowledge? And the corollary of that question is the way that organization affects the kind of knowledge that comes out the other end. So your notion of what the definition of the problem is differs according to how that social organization occurs. And also, once you have a definition of the problem, it sends you off in a direction to discover what the solution is. And that vision of what the solution is will differ as well according to the sociology of knowledge, essentially, the social organization of all of those actors who are knowledge producers. So it got me thinking about, how does that work in HIV, where there's a lot of money and a lot of actors around the world? And the first thing I started looking at is the place that prevention, first of all, plays in the larger AIDS establishment. And this is from an internal report generated from the Global Fund to Fight AIDS, Tuberculosis, and Malaria, which looked at the degree to which at-risk populations who are on the front lines of the epidemic are actually on the receiving end of resources from the Global Fund, which is, of course, the largest fund to address HIV around the world. And you can see from these figures that MSM, and that's their terminology in the report, we're getting about 2% of the overall funding. Sex workers about 3%, and people who inject drugs 3.5%. In other words, not too much. Of all of that funding around the world that is being devoted to HIV, these three groups, which are especially impacted, the most impacted, getting a pretty small amount of the resources for prevention. So I thought, well, what's happening with the Canadian Institutes of Health Research? The CIHR, of course, is the primary funding body in this country for HIV research. And so I did something very simple, and that is I went to their funding website, and according to their funding website, almost $100 million has been devoted to HIV research, or is devoted to projects that are still in their database that are ongoing. Pretty good number. I typed in the word prevention. About $22 million of that total then has the word prevention in the abstract. And then I looked at, so what populations are being addressed, and you can see, using the words IDU, sex work, and MSM, what the proportions of the prevention budget from CIHR are going to, again, the most affected risk groups in Canada. And really what that works out to is 9.7% of the research budget for grants mentioning HIV prevention also make any mention of MSM in a country where 51% of the epidemic is concentrated among gay and bisexual men. So again, it makes me wonder about proportionality. How are these resources being allocated? Does this make sense? Is this the way it should be? And I think this measure is a very crude measure. It doesn't do its homework by looking at what exactly were all of these projects about. And I think it's actually a generous mention because the abstract only had to mention MSM. It didn't have to say anything about what they were doing with MSM. So, you know, if gay and bisexual men were simply providing samples or whatever, and the research was not specifically for them, it would still turn up in the abstract. So it's the most, I think, generous construction of how much money is going towards gay and bisexual men. And incidentally, I did put in the word gay too, but you won't be surprised to know that if you put in gay, the number is very small. So MSM produced, again, the largest possible amount, and $2 million for prevention with gay men out of $100 million makes me wonder. So part of where this paper comes from, too, is my frustration at sitting in international AIDS conferences and Canadian AIDS conferences and wondering, trying to put a finger on my discontent, I guess, with those conferences. And so I looked at how prevention was addressed in the last 5 international AIDS conferences. And this begins to speak about where that money really is going to. You can see that the majority of the speakers treated prevention primarily or exclusively as a question of biomedical technology. Okay? And of the remainder, there are some who did speak to risk groups. 3 spoke about IDU, 2 on women, and 1 out of the 21 over 5 years spoke about gay and bisexual men at all. And there was one by a psychologist, which was actually about social interventions, the kinds of things that is the bread and butter of AIDS service organizations. So again, you see there's a certain hierarchy here that is emerging about where the money's going, where the attention is going, what is considered to be legitimate, important, and deserving of attention of the international AIDS community or establishment, if you will. The last line on this slide about the 2010 conference abstracts is this same findings that Len presented yesterday from the Global Forum on MSM and HIV, where they went through and also did a review of conference abstracts to see what percentage were being devoted in this instance to MSM, IDU, sex workers, or trans people. And again, the numbers are very small. And if you've attended those conferences, that certainly my impression was going there, it's like, where are the gay men? How have they become so marginalized that there might be one session that's a satellite at 6 o'clock at night, and that's the entire thing out of conference of, 20,000 people and huge amount of expenditure. And let me just also pay tribute to the presentations that Olivier and Len did yesterday. It's wonderful to see that there are now some careful accounting procedures that are being done to look at how funders are allocating resources. I hope this is a new wave, and that we all take this evidence on evidence-based research and ask our funders how they are allocating money in this area. Okay, so that's one aspect of my objective here, which is to look at the social organization of how knowledge is being produced, and it has a lot to do with where resources are put in the first place, because that funds the studies that produce the findings and the knowledge and so on. The next area that I want to talk about is the question of population science versus everyday practice. So here I'm going to start with another example that's away from the HIV area to try to give you an idea of what I've got in mind here. And that is that population science typically engages in a kind of actuarial reasoning about what the best way is to accomplish prevention. And one of the best places to look for actuarial reasoning, of course, is the insurance industry. That's their foundation. And so what we see in the insurance industry relating to driving, of course, is various kinds of demographic findings from insurance stats that categorize who's high risk and who's not high risk on the roads. And if you've ever paid an insurance premium, you're probably not surprised to find out that if you're male, and especially if you're under 25, you're going to pay a penalty because you're high risk, according to the demographics of the insurance industry. So this is population science, right? You've got a demographic category, you've identified who's high risk, and you've got a reason then for charging way more money for that category of people. But my concern is that there is a kind of disjuncture between that knowledge and everyday practice. And that disjuncture is that a finding like that, it doesn't tell you much if you are male and under 25 about how to drive safely. It actually doesn't help you. Or if you're not in that category and you're driving on roads and you encounter men who are, in this high-risk category, what you would do about that. So, in other words, it's a certain kind of knowledge from a certain kind of viewpoint, but for whom is it useful? It's useful in this instance to the insurance industry, but it's very hard to translate it over into knowledge that's useful for people trying to conduct their lives on a day-to-day basis. And that's something that worries me as well in HIV and in prevention studies, is how do we go from the population science level where there's a lot of money and a lot of epidemiological studies and a lot of demographic studies that place people into categories, and where we look at all these various demographic boxes, but how do we get from that knowledge then to be able to communicate to those of us, I include myself in that, who cope with HIV on a day-to-day basis in our everyday lives? It's hard. It's not an easy translation. So here's another example which kind of, I admit, irks me a lot when I've seen it in the literature, and I saw it presented at a conference at the Centers for Disease Control in Atlanta, which is a finding that younger men who have older partners have higher rates of seroconversion compared to those who do not. And this is not a new kind of finding. It's been found with other groups as well. But what do we learn from that? How does it affect, how we manage HIV risk in our everyday lives? And you can extend that logic out. So this is just age, right? You can look at ethnicity. So in the U.S. anyways, Latino men have higher rates of HIV. African American men have even higher rates of HIV. And obviously all of these are big proxies for having HIV. So if you have HIV, you have HIV. So does this mean that we start handing out advice that the best way to avoid HIV is to select partners who are young, white, and negative, exclusive tops? It's madness. It's madness. I mean, this is the population science might think that makes sense, but it's completely tone deaf to the realities of HIV management in everyday life, which is that if we hand out advice which encourages people to be racist, ageist, and to discriminate against HIV positive men, what result do we get? The result is actually worse situation in terms of risk, because people respond to those kinds of social context and discriminatory behaviors and disempowerment and act in compensatory ways so that you're not going to end up with the kind of result which population science seems to think is going to make sense. And I say, fortunately, there's my bottom line then, men will continue to love, care for, and have sex with men across age, sex, race, and serostatus lines, and good thing for that. But again, it's a question of like, who's producing what knowledge for what audience? So, another area I want to look at then in terms of where a lot of the investment in research goes and where a lot of intention goes then is back to this question of the biomedical predominance in the area, and particularly to the notion of treatment as prevention, or as it is sometimes said by some of its proponents, treatment is prevention. And I bring this up because it's such a predominant theme at World AIDS conferences and at the Canadian Association for HIV Research. If you go to plenaries and you go to the sessions on prevention, this is message number one that is often put forward as the way to go, and this is going to work. And so I want to trouble this notion a little bit, kind of bite at it in a few ways. One, internally by looking at in terms of its own logic, and then externally in terms of my sociology of science model here, and also in terms of what I've been talking about in the question of how you translate population science to everyday practice. So how does this translate to everyday practice? It's got some qualifications built into it, even just from the biomedical viewpoint. And the first one, and there's a good biomedical literature on this, is problems of equating viral load results in blood, semen, and vaginal secretions. So on the face of it, treatment as prevention has got a number of things going for it. I mean, the first thing is that in a world in which a lot of people who have HIV aren't getting adequate treatment, it's an argument at least that they get on treatment. That's good. And secondly, if getting more people on treatment does lower the viral load of the population and it does lower transmission, that's good too. But I guess my question is how much of our, should we put all our eggs into that basket, or is the investment or that we see in this as a primary method of doing prevention justified, and how does it translate into everyday life? And one of the problems with translating into everyday life is again that it's not a completely stable kind of viral load measuring. It's not a completely stable kind of thing. And there's another literature on viral blips, as they call it, which is that your viral load results can vary over time, essentially, and they often vary according to other conditions that people have, like herpes virus, HPV, and so on, and STIs, all of which can change that from time to time. As well, the goal, of course, is to reach undetectability in HIV positive people. And so just using Ontario as an example and digging around and looking at the figures, and this is one of the most favorable conditions to try to realize treatment as prevention, because it's in Canada we have a context of universal Medicare, and we have first world access to treatment and dedicated clinics for HIV treatment and so on. And yet the Ontario record is that it's estimated somewhere around a third of people who are positive don't know. And of those who are diagnosed, there's another 6% who are not in care. And there's another 13% who are in care but not on antiretrovirals. And there's another 14% who are in care and on antiretrovirals but do have detectable viral load. So that leaves only about a third that we've managed to get to the undetectable level, and that's in pretty favorable conditions. And there's a recent article published this year for the United States which says that the comparable figure of the United States is 19% of HIV positives have reached undetectability. So that's a little bit worrisome for how far we can go with treatment as prevention as an effective prevention tool. And then, if we turn over to this, if we look, this is modeling data here, then citing Wilson, in a population of 10,000 serodiscordant couples over 10 years, and you're just looking at people who are undetectable, they still estimate there'd be 215 transmissions from positive women to negative men, 425 the other way from positive men to negative women, and 3,524 transmissions from positive men to negative men. This is having reached undetectability. So I bring this up only as a question of, again, how we translate population science, numbers that might look good at general level, how do we translate that into our day-to-day life? And I think that's a question for AIDS service organizations, because we hand out advice to people on how to manage risk in daily life, not at this, high level. Then there's the social research that finds that these, when you hand out this kind of information, it gets processed by people in ways that are sometimes unexpected, perhaps. And that is that these studies find that men who then feel that viral load is a rationale for not having to practice safe sex. They may feel that, but it doesn't actually correlate with their real viral load. But what they feel is related to their behavior. So the social research again troubles a bit this perspective of the degree to which taking antiretrovirals is going to do the job of prevention. So it makes me worry a bit about the degree of investment that goes into the notion of HIV prevention as a kind of technological fix. And I think it fits the larger modernist faith that we have in societies like our own, that technology provides the answers. And it goes back to my first slide, which is sometimes that's not the best kind of knowledge, or the knowledge that's going to work or shows the most effectiveness. And a huge amount of the money that has been invested in this area has gone to biomedical research, which has shown very mixed results. I'm sure you're aware that from 25 years of vaccine research so far, There's not anything really on the horizon, or it seems to still be very far off as to whether something effective will be turned up. Circumcision got a lot of attention, but is not likely to be very meaningful in a country like this one. Microbicides, most of microbicide research is actually segued into various ways of applying ARVs topically. And so it's very related to the PEP and PrEP discussion, which is all about when do you take ARVs and do you put more people on ARVs, including people who are negative right now, as a prevention technique. And there's a fair amount of money and research and results that we see coming out on PrEP, which is putting, large numbers of people in risk categories on ARVs as a way of reducing transmission, and there's some effect. But the effect seems to be running somewhere in the 40 to 60% range, and then there are other studies that have been stopped even before concluding because the results are so poor. So it's hard to see where all of this is going and whether it will provide anything more than a supplement to the old-fashioned condom that we've had from the beginning. So what I want to do is to turn over and talk more about what has been a lot of the subject of this conference, which is more social kinds of solutions. And that is, what has been the most effective proven HIV prevention change to date? Something that seems to get no attention from what I can tell in World AIDS conferences. And that's the community mobilization of LGBT communities in the 80s and 90s. That produced a dramatic change and a dramatic fall in the rate of transmission. Is there something we can learn from that? Is that a historical event that's just gone? Why don't we research that? Well, why has it receded, into the past? And so it got me thinking about what do we still need to know on the social front. And I'm going to provide a number of ideas which I think need more attention, more investment, though this is far from an exhaustive list, and you probably have others that you can easily think of. I'm happy to talk about that. I just want to open up more space to talk about some alternatives and some ways in which resources should perhaps be devoted for alternatives. One of those which we've seen cited in some papers in this conference is Ron Stahl's notion of syndemics. Ron Stahl's work comes from a psychological perspective that identifies traits in personal development and psychological states largely, which predict risk. But I think there's another question to ask around Ron Stahl's work, that if we see that there are a set of men, and the Sex Now study, that was really interesting to see results that confirm Ron Stahl's observation. The next step then is to think about what circuits, what microcultures, what social niches, what social networks may be out there which are on the leading edges of the epidemic, and where men who show that vulnerability are located, to figure out how they can be engaged and to do better, be more focused than just using the MSM category to do prevention in ways that may be more effective. I think we've got more work to do in looking at popular strategies and folk wisdoms. This conference has raised several times the question of zero sorting, zero adaptation, and so on. These are all kind of, folk methods, popular methods that gay men are employing. There's more to, I think we need to come to grips with that, not just affirm everything that is happening out there, but if that is what is happening, to look at them and to see if these methods can be improved, if how reliable they are, how faulty they are, and to build on that as a knowledge base arising out of experience and out of everyday practice, rather than starting at population science and then trying to figure out how to get down to the everyday life level. One of the things that impresses me in interviewing gay men around HIV risk is how often some of the issues around safer sex decision making have to do with assumptions, interpretations of the rules of the game that govern sexual interactions. Where I find interviewing negative and positive men that they sometimes bring different conceptions about what's happening in the same sexual interaction. And those different conceptions sometimes set them up for risk, and sometimes, you know, they're entirely successful. I think we need to look as well more at the socio-historical movement of sexual and drug cultures. One of the reasons is that certainly in the U.S., the CDC's put a lot of attention into developing effective interventions, but I think a lot of those interventions themselves depend on the degree to which they are acceptable to the populations that they're designed for, and that acceptance can change over time. One of the problems of using the clinical trial model for evaluating interventions is the clinical trial model presumes that, you know, if you give people pills, you can figure out whether a pill is effective or not, and that's going to be the same whether you do it in 1970 or 1980 or in 2011. Is you know, the biological effect's not going to change over time. But the problem with doing interventions of a social type is they can change over time. You can do the same intervention 10 years later, and it worked great the first time around, and then the second time around, people thought, oh, well, that's boring. That's old-fashioned. I don't care. That's not interesting anymore. And it doesn't work. So we need to know about how, you know, the cultures of sexuality are moving, to be able to be engaged with where people are now. And it's going to work. So just a couple more points. Dynamics of popular mobilization. So as I said, one of the success stories, of course, has been the mobilization of LGBT communities around HIV, at least historically speaking. We're now left with the question of, is that over and done with? And one school of thinking says that, well, what's happened is that LGBT worlds have become increasingly fragmented into smaller scenes, microcultures, tribes, subsets, however you want to put it. If that's the case, then maybe that's the job we need to do, is to go out and find what the natural organization is of gay and bisexual men out there, and have a tailored approach to each of those different subgroups, rather than presume that's something that's going to work generically. Alternatively, I think we may not have fully exploited the degree to which gay men are interested in speaking to each other as a community. And I'll just mention the last big campaign that we did in Ontario with the support of the Ministry of Health, and that is HIVstigma.com. And HIVstigma.com essentially provided a website that invited gay and bisexual men to come and talk with each other about how we treat each other and how we may or may not stigmatize each other or over serostatus. And it resulted in a very vigorous, sometimes heated conversation, but a useful one, and one that we saw as advancing a kind of developing the ethics of a community, having a community itself grab hold of the issue and provide space to think through its own practices and how the practices that we have affect each other. A very different kind of way of thinking about prevention and intervention than a top-down approach. And I think I'm ending up here. So I think there are other areas that we need to know more about. One are actually competing sources of HIV discourses. Come from all kinds of different directions. They come from schools, or sometimes the problem is they don't come from schools. Why not? You know? Why are young gay men coming into gay worlds so underprepared? Shouldn't ministries of education be doing a better job there? And of course, there are many other sources. So I'll just end here by saying that I've made lots of sort of claims of fact, and if you want to look at the references, there is a paper which is available in an open source journal, so it's available online, and Cindy's office has very kindly actually made some hard copies too, so thank you.